So we will have to discuss this because it will be relevant for many, many aspects of our clinical job in the ICU. I mean, it will have impact for the ventilatory settings, and we will discuss this tomorrow morning. It has also impact on volume responsiveness, prediction, and also some impact on management of a patient with congestive heart failure. We will have to discuss this, and especially because we have to recognize some patterns at bedside. So the principle is that indeed the heart is in the chest. I think we will discuss this very often. And also one thing very important for us is that the left and right heart are both inside the pericardium. And of course this will have also major implication for the last aspects. So the changes in pleural pressure are transmitted to the pericardium and hence affect the left and right ventricle. And of course, we will rediscuss once again this issue of the transmural pressure, because indeed these two people can survive easily, but the real difference is that indeed the transmural pressure is totally identical. So indeed the zero pressure, as mentioned by Sheldon Magder, is very important, but we will see where the transmural and the intravascular pressure are important, because indeed some organs inside or outside the chest will live differently, these different pressure. And indeed, the pulmonary arterial occluded pressure as the pulmonary hydrostatic pressure, as well finally as a preload in this, is really the transmural one that is accounting. The pulmonary artery pressure as the afterload to the right ventricle is also the transmural one that is very important. For the intravascular one, the CVP as a back pressure for venous return or for liver congestion is also very important at the end. And finally, the aortic pressure for the liver afterload. One may think that basically these issues will be much more important in some diseases, especially, let's say, RDS, because indeed these patients are ventilated with high intrathoracic pressure. But of course, one problem is that the transmission of the alveolar to the pleural pressure is not straightforward, because sometimes it can be minimized. And indeed, this is affected by the compliance, but not only. But the compliance indeed will affect the fact that for the transmural pressure, in normal condition, 1/3 is transmitted to the pleural pressure. However, in RDS, because of the lack of compliance, only 20% sometimes is transmitted. So one may say, oh, it's less relevant in these conditions. It's also another factor is that the collapsed area are finally not transmitting pressure, so the resulting pressure may also be minimized. So finally, we will often see more complicated issues with hard lung interactions in COPD patients ventilated with high tidal volume, more sometimes than in RDS patients ventilated with same tidal volume. It is also important to realize that we can compute this driving pressure. Of course, we can insert esophageal balloon and try to measure it, but we can also indirectly measure it using the intravascular pressure. And this was really nicely illustrated by several papers, but this one is very nice from one of our chairmen, showing that indeed, looking at the gradient between the plateau pressure and the PEEP, the intrinsic PEEP here, and on the other hand, looking at the inspiratory, expiratory value of the pulmonary arterial occluded pressure, we can indeed compute what amount of pressure is indeed transmitted to the intravascular system. And indeed, in these conditions, it was also, in many of these papers, shown that it was lower in RDS patients than in other patients. So for the heart-lung interactions, ventilation-induced cyclic changes in intrathoracic pressure, and these changes will affect left ventricle and right ventricle preload and afterload. So there will be complex interactions we will try to dissect. So at inspiration, there is initially an increase in right ventricle afterload. And I will rapidly go over this because it's already been mentioned that indeed there can be indeed some stretching of the septal vessels that results indeed in the alveolar vessels in the increase in the resistance. And of course we will move from one to the other one with the mechanical ventilation. Several mechanisms included here, and we will not discuss this into much details. Interestingly, it seems that volume status is quite important, and this is also some data from our chairman here, showing that during high PEEP we can indeed increase the pulmonary vascular resistance, but by restoring some blood into the chest by performing a passive leg raising test, you can see in these conditions indeed that there is a decrease in the pulmonary vascular resistance in these conditions. So it's quite interesting to realize that just by better filling the extravalvular vessels, this can indeed decrease the resistance in the pulmonary tree. The other aspect is a decrease in right ventricular preload, and this is indeed very nicely demonstrated in the previous lecture, but here we'll look a little bit as a reverse, and basically indeed we will have to pay attention to the fact that some of these curves are really determined by the transmural pressure, while the venous return flow is indeed the intravascular one. So indeed, and this was indeed the slide presented by Sheldon Magder accompanying that paper, when we have indeed an increase in pleural pressure in these conditions, we have indeed these changes that can occur. And in this patient who will be volume responsive, we can see that there is a decrease in cardiac output as well as an increase in right arterial pressure. However, in a volume unresponsive, what we have is that we have, for the same increase in pleural pressure, we have here the translation, but no change in right arterial pressure and no change in cardiac output in this patient. So indeed, in these conditions, we can see that the heart-clotting interactions are quite important and will induce some different changes on the preload and on the stroke volume of the right heart. So basically, in many conditions, a decrease in right ventricular stroke volume, but not always. And this has also been demonstrated very nicely by echocardiography by Antoine Vera-Baron in this very nice experiment. Indeed, what they looked at the end-diastolic area and systolic area of the right ventricle at different phases of the inspiration. And what you can see is that there was a decrease in the stroke volume of the right ventricle at end inspiration compared to at the end expiration. But interestingly also, we can see that there was a decrease in the right ventricular preload because indeed the end-diastolic area decreased with the breath. And also there was an increase in the right ventricular afterload because there was an increase in the end systolic area. So both factors, at least in these patients, played a role in that condition. The last point is that indeed there could be also an increase in left ventricular preload as a purge effect of the intrapleural pressure on the alveolar pressure on the pulmonary vessels, pushing blood to the left ventricle. Another very important aspect is the decrease in left ventricular afterload, already mentioned by several speakers before, and so I have my own slide showing exactly the same effect, showing that indeed to generate the 80 millimeter here, if we have a 10 millimeter here, we have only to generate 70, so indeed a decrease in pleural pressure. So indeed these may increase left ventricular stroke volume, and this indeed compensate perhaps the other factor. During expiration, the factors will be slightly different. The first aspect is that there will be a decrease in left ventricular preload because of transmission of decreased right ventricle stroke volume to the left side after a few cardiac beats. And indeed, this has been nicely demonstrated here by Morgan, when you can see that there was a decrease in vena cava flow immediately when the positive pressure, at the onset of positive pressure inspiration. A few 2 beats later, we have here indeed a decrease in pulmonary artery flow. And here, a few beats later only, we have first this increase in aortic flow and then the decrease in aortic flow. Indeed, we can see the delay in the transmission to the left side of these factors affecting the right side. The use of heart-lung interactions to predict fluid responsiveness can be indeed used by several ways. We have the respiratory variation in stroke volume, we have the respiratory variation in vena cava size, and also the expiratory pause that can be done. The principle behind this, and this will be discussed more in details later on, is that indeed we have transient changes in preload induced by respiration or an external maneuver. What is the impact of mechanical ventilation on the right ventricle and the acute core pulmonary? This is also very important to realize. So basically here, we will focus on the increase in afterload of the right ventricle and the decrease in preload of the left ventricle occurring at the same time, but by the dilation of the right ventricle, which compresses the left ventricle because of the right-left interaction. And indeed, because we have the pericardium, when we have some pressure and dilation of the right ventricle, in this condition, of course, it will compress the left ventricle and induce some diastolic dysfunction in the left ventricle. As is nicely illustrated in this echo, when you can see here this dilation of the right side compressing totally the left side here of the ventricle. Interestingly, as shown by Antoine Verbaron, in this condition, when you have acute cardiopulmonary here, we can see that indeed in these conditions, the total heart volume doesn't change. But if we look at the left ventricular volume, there's a huge decrease in the left ventricular volume because of this compression of the left ventricle. This is one factor. The other very important factor is that the increase in pulmonary artery pressure increases the right ventricle but not the left ventricular systolic time. So in response to an increase in afterload, the left ventricle will indeed increase the pressure but not the systolic time. However, you can see here that when there is an increase in pulmonary pressure, there is an increase in the systolic time. As a result, there is here this gradient of pressure that is generated, and sometimes the pressure on the right side is higher than the pressure on the left side. And this induces a shift in the septum from the right to the left side. And this is nicely demonstrated here in this video when you can see here this flattening at end systole of the interventricular septum, reflecting this phenomenon here. And François Jardin mentioned this with the intravascular pressure measurements, measuring both the left ventricular pressure and the right ventricle here. At low PEEP, you can see that here the end systolic pressure is lower in the right ventricle than in the left ventricle. But interestingly, when they they applied a high PEEP in these patients, what they saw is that at that time, the right ventricular pressure became higher at end systole than the left ventricle one, and this was generating this paradoxical septal movement. The last point is the impact on the left ventricle, and indeed there we have to think always at two different parts. The first is that indeed the positive pressure will decrease the left ventricular preload, and this will have variable effects on cardiac output. Indeed, this will depend on the position on the Starling relationship when we begin to apply this positive pressure. If we are here on the flat part, no change will occur. If we are here on the left part here, on the steep part, indeed this will generate a decrease in the cardiac output or stroke volume of our patients. So applying PEEP in congestive heart failure will depend for the cardiac output on the impact on the preload of this patient. When these patients are well filled, this will be no major issues. So mostly beneficial hypervolemic and a little bit more problematic if our patients are hypovolemic at that time. The other point is a decrease in afterload. And of course, we may say that often this small pressure is really negligible, but we have to also remember that in many conditions, our patients are not really respiratory in quiet ventilation when they are in pulmonary edema, but mostly they are quite dyspneic, and then usually they generate quite negative pleural pressure, which can indeed be alleviated by applying positive pressure by CPAP or something like this. With this, I thank you for your attention.